It's 8 o'clock, so we're going to go ahead and get started. Good morning, everybody. My name is Arwa Nasser. I'm a member of the faculty at the Department of Pediatrics, Division Chief of General Pediatrics at the UNMC. And it is my pleasure this morning to introduce the other presenters for this presentation. This is going to be a group presentation. The other presenters for this morning are Dr. Laith Nasser, who is the professor of family medicine and vice dean for community medicine at Creighton University School of Medicine. Dr. Susan Kelly is an assistant professor of pediatrics at UNMC, and she's an emergency room physician here at Children's Hospital. And Dr. Gina Mora, who is an associate professor of obstetrics and gynecology at the University of Nebraska Medical Center College of Medicine. So the University of Nebraska Medical Center Global Mission is to promote the health through excellence in education, research, outreach, and care by creating accountable and strategic partnerships. And the Children's Hospital vision statement is to be a global leader in children's health. We took these mission and vision statements to heart, and in October of 2017, last October, the four of us met in Jerusalem, and we traveled to the Gaza Strip. We crossed the Erez checkpoint, which is one of only two checkpoints that is the entrance to the Gaza Strip from what is now Israel. So the Erez checkpoint is about 3/4 of a mile tunnel that's enclosed that one has to go through in order to enter from Israel to the Gaza Strip. And we went through, to deliver a 2-day continuing medical education course for the United Nations Relief and Works Agency physicians in the Gaza Strip. The United Nations Relief and Works Agency is a United Nations agency whose mission is to provide assistance for Palestinian refugees in the Near East. It provides several areas of assistance, including primary education, vocational education, and primary health care, in addition to some other services and food assistance for Palestinian refugees in the Middle East. About 17% of the UNRWA, is what we call it, budget is on health programs. They have health clinics, several health clinics throughout the Gaza Strip, and they provide primary health care for refugees. So what we wanted to do today is to share with you the experience that we had in, number one, developing this program and implementing it in this area. We also wanted to look at some unique and evolving challenges faced by refugee populations and discuss some educational needs of physicians and healthcare providers in areas providing care for refugee populations. So I'm going to stop here and turn it over to the other Dr. Nasser to give a little bit of a background about the Gaza Strip and the refugee populations, and then we'll move on. Sorry.
Too much technology.
Yeah. Here we are.
Uh-huh. Hello. So today I'm going to talk to you about the Gaza Strip. It's a long and complicated history, so I hope to make it understandable. to understand the current challenges in the area. So this trip was an unrestricted educational grant from Pfizer, so we have to disclose that. So the questions I'm going to answer today are, what is the Gaza Strip? And where is the Gaza? And what is UNRWA exactly? And what are the major events that have shaped the lives of people who live in the area? And finally, what the current situation in Gaza is, so you can understand the situation that we faced when we arrived there. So the Gaza Strip is this small, very small area, which is a self-governing area between Israel, Egypt, and the Mediterranean Sea. And about 2 million people live there, and so in 141 square miles. So it makes it really the third most populated region in the world. The majority, obviously, of the people there who are living there are refugees, but not all of them. There are indigenous people who've lived there forever. So I wanted to kind of give you a size check here against Nebraska. I made a little diagram there, and I stuck it up in Cherry County there, just past Valentine, to show you the relative size of Gaza Strip compared to the whole of Nebraska. So as you can see, it's a very, very small area with essentially all of Nebraska's population stuck in there. So to go back and to really understand this situation, you have to go back really to World War I. We're all very familiar with the history of World War I and the decisions that the great powers made after World War I that led directly to World War II, the rise of Nazi Germany and so on and so forth. What we're less familiar with are the decisions that were made in other parts of the world after World War I that really are impacting us today and really apply directly to the Gaza Strip. So if we look at 1914 map, we see the Ottoman Empire here. And the Ottoman Empire essentially was unchanged for about 700 years. It was this large empire that essentially had taken the entire Arab subcontinent. And so if you look there, you can see that all of these cities and what we now know as countries were essentially in the same country. There were no boundaries between these. So Baghdad, Damascus, Jerusalem, Tripoli, Aqaba, Mecca, all were in the same country. And for at least 700 years, all of these indigenous peoples, Muslims, Christians, and Jews, lived there fairly harmoniously and had their own culture and own systems of governance. This all changed after World War I. The great powers essentially divided up the spoils, as they did kind of in Europe, and they broke up the old Ottoman Empire. They broke it into Turkey. The French took and formed a new country that they had created called Syria, also another new country that they created called Lebanon. And the British took the areas that are now known as Palestine, Transjordan, Iraq, and broke them up into different countries and put in place leaders to do that. Now, the great powers had their own reasons for this, and their own reasons were, for the British, it was to stop gun smuggling. The British were facing their own uprising in India. And the Indians were trying to get their freedom from the British. And so there was a lot of gun smuggling going on through the Arab Peninsula. And so the British wanted to cut it off, and they did it by creating these countries and self-governing regions. So this is a little closer look at the area that we are now interested in. As you can see, there really is no border still between Palestine and the rest of the interior. This all changed in 1948 with the creation of the State of Israel. The indigenous Christian and Muslim populations were expelled to refugee camps. Well, they were essentially expelled to nowhere. They ended up, as you can see, these arrows show us, to Lebanon, into the West Bank, which had been retained by Jordan at the time. and interestingly, for our purposes, the Gaza Strip. So most of the population of the southern part of Palestine was expelled to the Gaza Strip. And it was a real humanitarian disaster that shocked the world at the time. People were essentially dying of starvation and disease. So finally, in 1949, the United Nations acted and created the United Nations Relief and Works Agency specifically to deal with this problem. They currently work in 5 areas where the major refugee camps, Palestinian refugee camps are. That's in Jordan, Lebanon, Syria, the West Bank, and Gaza. And its mandate at the time, and continues to be, to provide shelter, healthcare, and education to the displaced refugees who lost their homes and livelihood as a result of this conflict. Again, in 1967, Israel took more land and expelled more population. And so the Gaza Strip had a new influx of refugees at the time, as did other refugee camps. As you can see, this is a map of where current refugee camps are all over the Middle East. And down in the corner here is our area of interest, which is Gaza. And so there's quite a few refugee concentrations there. This is another map showing essentially the boundaries of Gaza. And although Gaza is nominally under the control of the local government, under international law, it's considered to be occupied by Israel since 1967 because Israel controls all of the borders and the airspace. Since 2007, Israel has imposed a land, sea, and air blockade on the territory. There's been ongoing military violence. There have been major assaults by Israel in 2008, 2009, 2012, and 2014. A total of 3,800 people were killed. 2,500 of these were civilians, and most of those were children. As you can see, there's been an application of quite a bit of military force with unsurprising results. A number of studies have been done showing that rates of PTSD among children are over 80% in the area, and hospitals are regularly overwhelmed by the needs of these situations. This is a map of the current situation in the Gaza Strip. As you can see, the strip is entirely blocked off by large walls and fences to the ground, to the land area, and there's a sea cordon that prevents much fishing from going on. So fishing is severely curtailed. So the current situation is that there's a blockade of goods in both directions from the Gaza Strip and to the Gaza Strip. Farming and fishing are severely restricted. There are rolling blackouts, 4 hours of electricity daily. Drinking water is unsafe due to the collapse of the wastewater treatment plants due to lack of energy. There's been a recent report that 97% of all drinking water in the Gaza Strip is contaminated with salt or sewage. Hospitals and clinics have no access to many essential medications. Most recently, there was a report from UNRWA that said over 200 essential medications are unavailable for them. Lack of fuel resulting in power cuts to hospitals, most recently, as well as clinics. About 1.6 million of the population of the 2 million people who live there suffer from food insecurity. Large numbers of people are unemployed. Younger people, the unemployment rate is around 75 to 80%. The overall prevalence of anemia among preschool children is about 60%. 40% of pregnant women are anemic, and 20% of children suffer from stunting due to malnutrition. And so that is the current situation, and I'm going to hand it back off to Dr. Kelly. Thank you.
So against that background, I wanted to talk a little bit about why it was we chose medical education to bring in to try to affect the situation that exists currently. And to do that, I want to take a step back and talk about different approaches to health promotion. This is a diagram that came directly out of an introductory text to healthcare promotion, and there are multiple different diagrams that can depict this idea, but I like this one for its simplicity. So there are 5 different basic approaches: the medical approach that we're all most familiar with, as well as behavior change, education, empowerment, and social change. I'm going to skip over the aims that you can read on your own and talk a little bit about the methodology and tie in kind of the worker-client relationship as I talk about the methods. So again, we all operate with the medical approach most of the time as experts being healthcare practitioners, doing screenings, providing individual risk assessments, and then making recommendations to improve health. The behavior change approach is also usually an expert-led approach that attempts to persuade clients using one-on-one interactions. The educational approach may be expert-led or may be a partnership between an expert and clients to share information and explore attitudes. Empowerment, the health promoter is the facilitator and uses methodologies such as advocacy, networking, and facilitation. And then social change is the development of organizational policy, public health legislation, and lobbying. So the practice of medicine requires practitioners to use a variety of approaches. In my day-to-day work and in yours, we most commonly rely on the medical and educational approaches. I spend a lot of time educating patients and families in the emergency department, in part because I believe effective education fuels empowerment and behavior change. That then leads to the question, what happens when health practitioners are educated, and can health provider education affect the health of a population? You can see here the definition of continuing medical education that's provided by the Accreditation Council for Continuing Medical Education. Continuing medical education consists of educational activities that serve to maintain, develop, or increase the knowledge, skills, and professional performance and relationships that a physician uses to provide services to patients, the public, or the profession. The content of CME is the body of knowledge and skills generally recognized and accepted as within the basic medical sciences, the disciplines of clinical medicine, and the provision of healthcare to the public. Therefore, the goal of medical education is to change knowledge, attitudes, or skills. There are obviously challenges in regular medical education when people speak the same language and have generally the same cultural backgrounds. There are unique challenges in thinking about developing and then administering an intercultural continuing medical education course. To start off with, I wanted to kind of state the obvious and say that there are differences in medical education and then expectations. And I wanted to read an excerpt from a woman, Jessica Shinnick, who's an American lecturing at the Rotterdam School of Business in the Netherlands. And she has shared some of her experiences in intercultural education online and in the business literature. She says that students from different countries have different educational experiences and consequently have varying expectations of both their teachers and their classmates. Some students expect to be lectured in a traditional format with a teacher-centered approach and a focus on theory, while others seek more dialogue and discussion. These different experiences and expectations necessarily influence the way in which the student behaves in the classroom. The position of the international student spans a wide spectrum, ranging from a silent listener to an active challenger. Differing views about the interaction between lecturers and students and among peers has indeed been found to add to the level of complexity to the learning environment and in multicultural classrooms. And so it's essential in preparing to give a lecture in an intercultural setting to have some insight into your learners, their style of learning, and some of their background. And so to start with the basics of medical education, the educational system is different than what I have experienced here in the United States. So at the end of medical school, there is a 1-year training program, and most of the participants in the course would be general practitioners who have had 1 year of a formal residency program after medical school in general medicine, which is a lot different than the 3-year program in pediatrics that most of us in this room are either completing or have finished. And then there are differences in access and exposure to continuing medical education. which again helps to formulate what ideas the participants may have in coming in and what they're expecting to get out of the course. And the answer to this is rather surprising because the participants had never really done any sort of formal course that we all take for granted in the United States. In fact, while online options may be available, this was the first time that any of the participants had been in an in-person continuing medical education conference. And then the other challenges to consider are differences in the primary healthcare structure and delivery and differences in the specialty healthcare structure and delivery. The goal of medical education is to change knowledge, attitudes, and skills. To be an effective teacher, I needed to learn about the healthcare resources and delivery system to help align the content with what could be implemented locally. Then I want to spend the rest of these few minutes talking about our team's approaches to the challenges. So first, it's essential to assess the needs of participants, and all of this groundwork had been laid by Dr. Nasser. So she started with partnering with UNRWA, asking what they would find most beneficial. And rather than asking for additional providers to provide direct patient care, they requested continuing medical education. The first course was held in Jordan in 2016, and based on the feedback from that course, the course content for this course in 2017 was designed. And then we needed to gain exposure to the healthcare environment. When we arrived in Gaza, prior to the start of the course, we were welcomed by many of the UNRWA healthcare leaders. And after they gave us kind of an overview of some of the statistics and the numbers and the general structure of the organization, they took us on a tour so that we could see kind of hands-on what their healthcare providers' day-to-day work looked like. You've already seen this picture once. None of us took a picture of the place that we actually went to, but all of the buildings architecturally look the same. So all of them literally look like this, except that this one is still under construction and doesn't have people everywhere. So this is what the outside of the primary healthcare centers for UNRWA look like. And then I'm a pediatrician, so of course I took a lot of pictures in the pediatrics room. So we interrupted this lovely doctor in the middle of his busy morning of clinic to see what his kind of workflow looks like. And so on the upper left, if you use your imagination, you can kind of see that there's something that looks like a growth chart on that computer. And sure enough, it is a growth chart. So they started by sharing some of the electronic tools that they have available and showed us what the electronic medical record looks like. And it has all of the components that you need to evaluate ongoing growth and development of healthy children, including World Health Organization growth charts. And then we moved on to see what the backup system is. So in a place that doesn't have terribly reliable electricity, it is helpful to figure out how you're going to have some information when the computers crash. And the answer is, well, there are great tools that are on paper that you can use. Some of you who have worked in non-US settings may find this to be familiar picture. This is a picture of a booklet that is published by the World Health Organization, and this is a mother-child booklet that talks about some prenatal care, but also documents some of the initial care for babies. I took a picture of a random baby's newborn assessment. So this is literally the birth history in a little bit bigger than maybe a 4x6 is about how big this document is. And it gives you all of the basic information that you would want to know about whether this was a term or a preterm baby, how big the baby was, whether there were any complications. And it just gives you a quick picture of kind of the beginning of this child's life. Included in this is a growth chart for the baby for the first 2 years of life. And then it also includes all of the vaccines. And so while UNRWA provides all of the primary health care in Gaza, if they were to need to seek healthcare elsewhere, this is a wonderful thing that all parents are requested to keep on them to be able to share with other healthcare providers, to be able to give information. Prior to the trip, I was given a book to read to help me understand a little of the history and current situation that Dr. Nasser described. The book was called The Night in Gaza, and it's written by a Norwegian volunteer doctor who's a photographer, and he provided stories and pictures to share his experiences working at this hospital, Al-Shifa Hospital, during the 2014 bombing of Gaza. Partially because I read the book, I was hoping that we would be able to stop by, and we were able to have a tour of this facility, which is the tertiary care hospital in Gaza. I do pediatric emergency medicine, so I was obviously interested in the emergency department and learned many things about the structure of how they provide emergency care. So in my world, medical and surgical emergencies are all handled and screened in the same place, and there they are split. And so to the right, you can see a picture of what's very normal picture in my world. This is a trauma bay, but it's a subset of the surgical emergency department, which again is split from where the medical emergencies are handled. And then after gaining exposure to the healthcare environment, the last approach that is necessary when working in an intercultural setting is just being flexible and frankly having a sense of humor when things don't go quite as you expected. So flexibility was required before, during, and after the course. Before the course, I needed to do some research myself to figure out, again, trying to understand what the healthcare providers that I was attempting to collaborate with, what their background would be. And so for me, it was helpful to figure out what the World Health Organization classification was, and also to get a sense of the World Bank classification. So the World Health Organization has different regions of the world, and Gaza is considered one of the occupied Palestinian territories in the same category as Lebanon and Jordan. And it is part of the Eastern Mediterranean Office. So that gave me some information when interpreting statistics about various things. One of my presentations was on burns, and burns are inequitably distributed in the world. So knowing which World Health Organization region we were talking about helped me understand what the prevalence of burns might be and what the mortality rates were likely to be in the region. And then the second piece of information that was helpful to me is to compare it to Jordan and Lebanon to figure out what the income classification was. And it's both of those countries are considered to be middle-income countries. I have spent some time in a low-income country, and so this was a different experience for me because there's frankly a little bit more access to medical equipment and medical care than in a low-income country, but is still a unique niche different from the high-income country where I practice most of the time. And then during the course, again, this idea that different learners have different expectations of the interaction with the lecturer, and it quickly became clear that the learners were very eager to interact and had lots of fantastic questions. And so while the first lecture that I gave, I had more of a traditional didactic approach, which is what we're using this morning, in the subsequent lectures, I gave a little bit more time to talk and interact, and really enjoyed the experience of being able to do more question and answer sessions. And then immediately after the course is one of the best times to reflect on how the course went as a whole, and to figure out what could be used next time if there were to be a next time. And so these were the co-course directors, Dr. Nasser, that you will recognize, and Dr. Gada, who is the UNRWA field director. And we were able to sit down immediately after the course with her and talk about kind of co-impressions of how things went and strategize about directions for the future. So with that, I'm going to turn this over to Dr. Amora. I don't remember what yours is called.
Alt-tab.
Alt-tab.
I think that's me. Okay, good. All right. Well, thank you, and thank you for your attention on this. This was just for me, it was an amazing experience, and I've had I've participated in other programs in other parts of the world, either for providing medical care or more often for providing continuing education, and this one was just exceptional, and so. I thought it was a tennis ball anyway. But just very special, and I felt like was a strong accomplishment, and that is mostly on the shoulders of Dr. Arwa because of the background preparation that Susan has described. I wanted to just highlight today a few of the things that were some of my important, for me, really the important impressions and takeaways that I had from this experience. So The first one was that, we've seen this kind of view already of this, of just that we had the vision even going in that this was going to be a pretty potentially kind of daunting experience, and a population that was living under crushing poverty and really intense restrictions and regulations. And so kind of this preparation for doom and gloom. And then strangely, of course, we found when you're actually living in the population for even a few days that, we would see out on the promenade 3-4 weddings every night. And, just to be reminded, it was interesting to me, in one of the talks that Dr. Lath gave was about depression. And you get into really interesting kind of cross-cultural discussions when you're having a discussion about mental health, because it by its very nature brings out in the discussants how this is approached and what the cultural viewpoints are, and even just how to take a history. And as he was giving some of his key tips on history taking in the area of mental health, one of them was asking about if somebody feels hopeless. And if they feel hopeless, then you should pursue, and questions about suicidal ideation and this. And the person sitting next to me, who was one of the locals, was like, if you feel hopeless, everybody here feels hopeless. It was like this, you sort of have this little check on yourself of, what of our traditional training works or doesn't work? What gets lost in the translation? But I was also just, reminded about part of this, I think, speaks to the resiliency of these people, of this culture, and part of it is just the human condition, that even in very desperate situations, people don't live in hopelessness all the time. The other thing, though, as we got into really the group that we were working with, what I was just so struck by was that this was the most, I've, just in the U.S., I'm working with medical students and doing, working with residents and doing continuing education all the time. And I was just dumbfounded at how, at the level of engagement of these physicians. And it, to me, really stemmed from this, the background that had been done, the amount of interaction that we were able to have even before the course. I think that was, as Susan has talked about, I think that was really critical, that people were able to have a voice in who came, and because I don't think that Dr. Arwa was necessarily even planning on, in the first time that she did this continuing education series, to even have somebody from OBGYN there. And then it became clear that this was a need that they had expressed interest in. And so being able to actually listen and respond to what their described needs were. And that was really coming from the leadership level. The picture I have here is really the leadership team. And again, we see Dr. Agata on the second one from the right there, who was just epitome of servant leader, of somebody who clearly took responsibility and accountability, but was an incredible listener to the rest of her leadership team. And it was clear that while everybody in her, in the entire cohort of these primary care physicians who were able to attend the conference, that they had incredible amount of respect for her, but that they all felt that their voice could and should be heard and would actually be listened to. So the sense of agency that you see in these physicians, you realize this is no coincidence. This is really baked into the way that the structure of this healthcare system worked, which I just found to be astounding. Part of this is, they're working in a system where there are, so for example, I did talks on preeclampsia, contraception, and preconception care. They initially had expressed interest in having me talk about preventive care generally for women, for the female population. I was able to, with the assistance of Arwa and then Dr. Gada, to get connected with the people there who could actually provide me the information beforehand to know, what does your system actually look like? If you're asking for a talk on preventive care, well, preventive care for us, as we know, for women's preventive care is pap smears and mammograms and prenatal care and that sort of thing. So it's like, is this something that you even have? I've fallen into this trap before of one time doing continuing education in Afghanistan and being asked to talk about cervical cancer, and foolishly started with slides on pap screening and the benefit of that, to realize that not one person in my audience had ever performed a pap. That was completely outside of the realm of their resources. So and so here again, to find that pap screening is not something that they have. Most of our discussions around paps and HPV and all that, no point in going there. So I was able to turn that talk into really just talking about preconception care, understanding what is available for folks in terms of their contraceptive access, which was pretty good. He had told me, don't worry about pills or patches and rings and that sort of thing. We do pills and IUD, but IUD is quite well utilized there. They unfortunately don't have the hormonal IUD that we have, which would be of tremendous population benefit to them. But at any rate, to have this kind of dialogue before we even went really helped to inform our presentation so that we could give the most relevant information as possible. And then their interaction as far as asking us about how do we, one of the interesting questions that came up after one of the talks was about hepatitis screening, which, as you all know, we do just routinely in prenatal care. And for them to say, I wonder if that should be part of our screening. I mean, their screening right now, their first visit is an RH type, a hemoglobin, a urinalysis, and a random glucose, as opposed to the much larger panel, of course, that we do for obstetric care. But that they stopped and said, I wonder if hepatitis B would be worth screening. And then we sort of started on this little, side project of looking at the World Health recommendations. And is this something that you could potentially make the case to the highest levels of UNRWA to say, actually, this is endemic enough in our population that the cost benefit is there and that we should add this. But I mean, you just think about, at the end of most of our continuing education talks, with physicians that have tremendous resources at their fingertips, that kind of just excitement and level of engagement was something extraordinary and really new to see. So again, this is the leadership team. This is our kind of final sort of graduation picture. And I'll get to in a second sort of what the backstory on that. This was another fascinating piece for me on just the physician engagement, that these folks were delighted to talk to us about their electronic medical record. And you kind of felt like, I've walked through some looking glass here of what is going on? You guys are excited about your electronic medical record. This is our major point for, we bond by commiserating over our medical records and the burden that they've put on us. But then you look at, and I don't know how well this shows, but anyway, this was a medical record system. I mean, they have in some ways the good fortune of not worrying about their billing codes and all that, so they get to keep the focus. But it makes you realize what this could look like when there really is physician engagement. This was a medical record designed to help them practice medicine better. I mean, one of the flags that they loved that they would have in their system was to flag that the patient is preconceptional. And preconception care has been this big buzzword in obstetrics and in primary care for the last decade. But somehow still keeps kind of falling through the cracks because we get very problem focused and da-da-da. So it's like, well, that's really interesting that could be something that would be built into a system. But that takes physicians saying, let's make a system where you can click on these various pieces, and if somebody falls out into a high risk or an alert stage, then the appropriate flags come up. So they loved this thing, that it helped them to look at their infant and child care differently and better, and in ways that they felt were really relevant to them. And so similarly on the obstetrics piece. The other big point, I guess, that I would just say is that for people interested in global health, I would very strongly encourage you to do it. It's a life-changing, mind-changing kind of experience. I would beseech you to do it in a way that emphasizes healthcare education rather than healthcare provision. For those, I don't know if we've got medical students in the audience, but I think sometimes for when we're quite early in our careers, our vision of ourselves is that any little thing that we could do for another population might feel like a really big impact. And I would just point out to you that actually as a med student, and all of us as practitioners, if we've trained in this country, the exposure that we have to teaching people about communication skills. I mean, at UNMC, the course that we call ICE, that's teaching about communication skills and patient interviewing and working with difficult patients and the sorts of things that we kind of roll our eyes when we're going through it. This doesn't really feel like it's the core of it. But to bear in mind, that is like, sort of gold plating on an education, on a medical education that most countries around the world do not get. And to have those kinds of interactions with people practicing in other or learning medicine in other areas, to have this sort of dialogue about what does patient autonomy look like in your context versus mine. What does decision-making look like? How do families fit into the decision-making? There is just tremendous benefit, long-lasting impact that you can have when you step into another culture and do so as a healthcare educator and leave behind that kind of impact on folks. So I would just put a big plug in for that although it seems maybe more enticing or exotic to actually go and provide care, doing this work on actually educating the people that are living in that culture is, I think, much more impactful. So these were just pictures of our highly engaged audience. They were going over some laminated sheets that I had provided with the medical eligibility criteria for contraception, and they just ate that up. Again, this was a situation where they couldn't really rely on online guidelines and that sort of thing that we rely on a daily basis here. So just to have that kind of hands-on piece was really important. And then this, just as a reminder of kind of the level of fun, I guess, that these folks had, was just that to get this picture, which looks pretty straightforward, this was kind of the graduation picture, was, in my memory, was like a half an hour experience, because what it mostly looked like was a lot of this and people wanting a selfie with the group and all this stuff. But, again, it speaks to the level of kind of just friendliness among the crowd, and that they took their work seriously, but also enjoyed just the fun and the friendliness of it. So anyway, it was an amazing and very important educational experience for us, and hopefully for them as well. Thanks.
Okay, so a lot to talk about. I just wanted to pick up on one of the things that Jean said about the electronic medical records too. In one of my earlier trips, when I was meeting with the leadership, one time after a meeting, they told me that they were going to a opening of a new health center, and if I wanted to ride with them and to go to that opening ceremony. So I went, rode in the little bus with them. And there was a lady sitting next to me, so I was starting to have conversation with her. I asked her what she did, and she said, I built the electronic medical records, just so like as if it's just something you do every day. And I said, what? We just paid $80 million in my institution to do that. But they actually did. They built it from the ground up, and it was basically based on the needs of physicians. They just put in it what they needed to make it easy for the physicians to access the information that they needed, and to have all the information that they needed at their fingertips. So this is one of my earlier meetings with the leadership. We started talking about this again several years ago, and as Susan mentioned, we went ahead and officially did a needs assessment for their educational needs for the physicians. We did this initial educational needs assessment with the Jordan cohort of physicians. We sent a survey about their educational needs, and were able to publish the result of that research in the Eastern Mediterranean Health Journal, which is the journal of the WHO. The results that we got is that most of the physicians in the Jordan group, which was about, there were like 95 physicians in the total group. We got 89 responses back, which is a very high response rate, indicating the level of engagement really of these physicians. But most of them have engaged this, and this is again the Jordan group, in some form of medical education, including accessing medical websites and medical journals and so on and so forth. But mostly they did seem to prefer lectures and brief courses. However, when we asked them about their preferred methods of continuing medical education, medical conferences really ranked highest in addition to brief courses, and those are all the live conferences that people preferred. And this is really consistent with international literature that shows that despite the boom in online education and all that's present there for exchange of knowledge on the internet, still medical conferences are big and thriving, even here in the United States. If anybody goes to the AAP meetings every year, they break a record on how many attendees there are. And this is because live conferences provide the human interaction, the ability to ask questions and connect and network. And then this just like networking and camaraderie and the meeting of other professionals like you. So live medical conferences continue to be preferred, and this was their preferred mode of education. And this was especially true for the Gaza physicians, just because of the blockade. Some of them have not been to any live conference with anybody outside Gaza for the past 10 years. So that was specifically important for them and very well appreciated. So this is the conference that we put together, again, based on their preferences, and we incorporated obstetrics because that's something that they really asked for. Jean's presentations were wildly appreciated and successful, and we got very good reviews of them. We also had to modify the course a little bit we actually canceled one of the presentations just to provide a full 1 hour session of just question and answer, which was very highly appreciated. And they asked question for an entire hour. This is the program evaluation showing that Sarah Weber here from the Continuing Medical Education office at UNMC, who helped and really made things work for us there. The information, the response to the question of if the information enhanced your current knowledge, and the majority, almost 100%, felt that it did. And then the more important question is, about 92% felt that the information they would apply the new knowledge that they gained in this educational activity in their daily work. Some of the narrative comments also just speak to how really much they appreciated the information presented. And then, like Jean said, they were asking me afterwards. I gave a presentation on common presenting symptoms for young children in the newborn period. They all came to me and asked how can they get bilirubinometer in their clinics, and how they can implement the MCHAT, which is the autism screening. They have not been doing that before, or maybe use it as a tool to diagnose patients. Again, the contraception talk was very popular, and again, a lot of very positive comments from the attendees. So it really has been a tremendous experience seeing the level of engagement of the physician and the pride they took in their work, and feeling that they were providing really good health care for the people that they are taking care of. And there is, as had been mentioned before, although it is this, they really work under tremendously harsh conditions with really they have a rolling 4-hour electricity on. People told us that they use the refrigerators to put their clothes in because they can't, they only have 4 hours of electricity every day. I wanted to incorporate a video, but I couldn't cut it out of the full thing. That was the inspiration for the title of this course. Susan was giving her presentation on burns, and in the middle of her presentation, the electricity went off. And for probably 2 or 3 minutes, while the generator kicked in, Susan just didn't miss a beat and continued to talk through no electricity in a dark room without slides. So, in spite of all this, really, I think the level of engagement and the specific situation that, although they are under really these harsh conditions, they still, for their care, feel that they use international guidelines and evidence-based practices to care for their patients, and they were very eager to share that with us and to engage with us on these levels. For the future, we are continuing now to work on the presentations that we gave, to polish them, modify them based on feedback, and perhaps create educational modules that we can put online that can be helpful for this particular group and perhaps other groups in the future. We want to continue to develop different topics to kind of make potentially a holistic curriculum that can be also put online and be implemented in different areas. We would like to continue on with these live conferences because, again, especially for the Gaza people and for the people in the other UNRWA regions, those proved to be of tremendous value to them. And then to work on establishing a bidirectional educational scholars program where they can visit us here and see what we do, and then we can have some of our students, residents, and physicians go and see how things are and establish this bidirectional educational opportunities for both sides. Lastly, again, as Jean mentioned, and all of us did, despite the harsh conditions and restrictions that people undergo, it's really remarkable to see their level of resilience and their level of fun and interaction. And this is on the last day of the course, we were walking on the corniche, what they call it, and we started to hear music. And it was a wedding party. So I'm going to play a small clip here to show that. The wedding party came, and the band was on the bed of a pickup truck playing, and then the party came out of the cars in the middle of the street. There wasn't much traffic, but then I'll let the video speak for itself. All picked up and drove off. So that's all we have for today. We'll open up for questions. We have a few minutes. Questions for all of us?
What about language? Are the physicians all
Yes.
completely English speaking, and is there an issue with that?
Right. So yes, the language of UNRWA medical is English. The electronic medical record is in English. Some of those physicians trained in actually Eastern European countries. Some are trained in Arab countries, but they teach medicine in English. For example, Egypt and Jordan teach medicine in English. But most of them, the language of communication is English, although all of them obviously are Arabic speaking and then communicate with their patients in Arabic.
When you were there, your sense, how much is security an issue
Right.
for people? And if you were to do that again, political situation has changed over the last few months, and
Yeah.
how would that play into your...
I don't know if anybody wants to respond to this. I'll just respond briefly, but see if anybody else has anything else to say. So we did have to get permission from Israel to get into Gaza, so that process took several weeks to get us permission to go in. As you might have noticed from the pictures, when we went in, we were the only people going in that day. So there really is no movement to Gaza for or in or out of it. When we were going out, there were 5 other parties. All of them were a child and an adult, and they were all cancer patients leaving Gaza to get cancer treatment and come back. Again, inside Gaza, there was nothing happening. We didn't feel unsafe at all. And I will let some other people also talk about their experience with this. I don't know, did you want
To throw in there, we weren't allowed to go anywhere on our own, with the exception of at the end when we begged. So we were escorted in an armored vehicle, and so that would have been my first experience ever being in an armored car. All of them were labeled as United Nations vehicle, with the hope that no harm would come to us if we were in labeled vehicles. At the end, we begged enough, and Dr. Nasser's both speak Arabic, and so they let us go on walks outside, but their preference was to try to keep us as safe as possible, and we're very mindful that they could make no guarantees. But that being said, while the process of getting into Gaza was exceedingly stressful and I was aware of all the security measures, once we were in Gaza, I didn't feel unsafe at any time.
I remember, what struck at me was that I felt personally so completely safe. And I remember as we were driving around in the armored vehicle, we kept wanting to roll the windows down so we could take better pictures. And they were like, the windows don't go down. Do you not understand how this works? So, yeah, I certainly did not feel any imminent threat at any time.
Right. Actually, one of the guys who spoke to you was from Ohio, wasn't he?
Oh, yeah.
Yeah. So, I mean, you've got people from all over the place in Gaza, just like anywhere else.
One shopkeeper had gotten his PhD from
Ohio.
Yeah. Well, and most people have some level of proficiency in English because English is taught in primary schools. So most people will be able to kind of, speak something to you or communicate.
What's like the support for like neonatal resuscitation? Have you guys witnessed were able to evaluate that?
Right. So we didn't get an opportunity to look at that because the UNRWA is only primary care.
I see.
So the hospitals, the deliveries all happen at the hospitals. They are on the receiving end of the newborn babies after they leave the hospital, and really this is one of the highest areas of need is the management of the newborn and young infant outside the hospital. So we gave a presentation on that, and this is something that always comes up as questions. But we don't know exactly what happens inside the hospitals. I didn't get into that. I know one of my colleagues in medical school, she trained in France in neonatology, and now she works, there's a huge, probably state-of-the-art hospital in Bethlehem that's built by the French that she works in. And my communication with her, it's, they provide great care and have good results, like, state-of-the-art like we have here. But I don't have first-hand knowledge on that. Okay, we're past time. Thank you all very much for your attention.
Thank you.